Well, thank you all so much for joining us. It's right at the top of the hour. And as you can see, we do like to have fun around here. So you never know if you come a little bit early what we'll be talking about. But right now we are on the last webinar of this 5-part series of this quality improvement series. It's been a wonderful series. And today we'll be talking about patient-centered medical home and the ins and outs of implementation. As you can see, this presentation is being recorded. And as soon as we get all these presentations uploaded and posted on our website, we'll be sending an email out with a link to all of those. So thank you all again for joining us today. I'm Kim Mayo, and I'm a program specialist here with the DRCHSD program, which is providing today's webinar. So if you will take a moment and not only tell us about your pets, but tell us about you. Tell us about your name, your organization, and what you do there. And that just kind of helps us to all find that chat feature and all know who's here with us. And we'll be using the chat for discussion today, so feel free at any point to add any comments or questions that you may have there, and we'll be utilizing that. So find it and use it. You can also unmute if you have that ability to do that as well, and we'd love to hear from you. All right, so we'll go to the next slide, and that is our funding statement there. So we always acknowledge that the Delta program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Authority. All right, so as we get started, and as I introduce our speaker today, Caleb's going to pull up some polling questions for us. All right, so you've got a couple of polling questions there. We would love to hear from you on. Just the one question today, so not too bad. All right, well, we have Angie Charlet again with us today. She is, this is, again, her 5th time being with us, and we are just thrilled that she is here with us today. And just a reminder, she is a registered nurse with over 30 years of experience in healthcare. She has a bachelor's degree in nursing and a dual master's degree in both healthcare administration and business administration, and a doctorate in business administration. And she is certified in both Lean Six Sigma and Black Belt and Six Sigma. She has over 12 years experience in the rural health helping hospitals and clinics improve their workflow, enhance their quality outcomes, and implement new service lines with their hospitals and clinics. So we are, again, just very honored that Angie could be here with us today. And thank you for taking that poll, and we'll share those results. We're all over the board. So Angie,
we are.
Yeah. So share your knowledge with us.
All right. So I am excited, you guys. I will tell you up front, you're going to get some of the Angie biases in this. I'll be perfectly honest. And I absolutely love patient-centered medical home. And I'm going to tell you why. And so we're going to talk about the ins and outs of PCMH structure, but in, all the years I've been doing healthcare, and back in the day when I was in the clinics, this is just the right thing to do. Whether you seek accreditation or not is your decision, but it's just the right thing to do. And as we really strive to become provider of choice, we want to look at what can we do to really engage our community and engage with our community. It's not just about us, making that, almighty dollar. It's really about us serving our community and how we get to serve our community, not because we have to, but because we get to, and I'm just such a believer in this. So we are going to be using the chat box. So I'm going to pull mine up here too as well. So I do have other screens I can share. This is where I want to hear from you. What is holding you back from looking at patient-centered medical home? And as we go through these learning objectives, really starting to, look at the key components, identify some of the benefits and the staff actions and what they should be doing, you're going to find that a lot of this you're already doing. So, it's truly a time to start looking at, okay, what am I not doing? So I can, really start to pursue and seek, that recognition. So now I'm going to shut my video off now that we've gone through these, because I talk with my hands everywhere. So, it can get distracting. So I am going to stop my video just so you guys can look at the slides and kind of pay attention to them. So again, we're going to go through all of this. So let's look at patient-centered medical home. It's really about emphasizing the relationship of the patient and provider, and having that go-to provider. So and I will use my examples as well. I have a provider, his name is Dr. Drew Van Kerbrock, and he is at one of my local critical access hospitals. And we do have a very good relationship, and it's that patient-provider relationship. When I go to his office, I think it's just kind of set in stone that I see him. I don't see one of the nurse practitioners unless, I'm really sick or I need immediate care, but I see him, and all the staff know me. When we think about that relationship, we already have a lot of that built in. So, and then our patient-centered medical home, it really improves the healthcare quality and efficiency of the delivery of what we're doing. So we're looking at, what does the patient need? What can I provide for that patient? Even if it's just a touch point. So when we look at, how are we improving our patient outcomes and our patient experience, but also us as providers, how we're truly embracing and, playing that role and, meeting our needs as providers with our patients. So there are a couple of accrediting bodies. Now I say HRSA contracts with, and this isn't necessarily, that they only contract with these. When you go out on the HRSA site, this is what's listed. NCQA, Joint Commission, and Quad A, are listed there immediately. But there are others, the compliance team, and I know HRSA works with the compliance team as well, but for some reason the website is not updated, to reflect that. And then URAC also, as a utilization review, has an accrediting body aspect of patient-centered medical home. Now, I'm going to tell you, I'm only going to talk about two, kind of more so than any others. And this is, I'll be honest, this is an Angie bias, NCQA and the compliance team. And I like both, and I like both for different reasons. Now, I will also preface this as I do serve with the compliance team as one of their PCMH facilitators and surveyors. So yes, I do have a stronger bias towards them, but there's other reasons for that. And you'll see that when we kind of go through this. But I like both. I have helped clinics achieve both through NCQA and the compliance team, just as an outside consultant. I've worked with the Joint Commission as well, and I've also worked with Quad A. But, these two are the two that I'm going to kind of be honing in on as we go through some of this. But I do have resources for everybody for all of them. Whoops, wrong way. All right, so our characteristics. So what do we need? What are we getting out of this? We have that personal physician. Just like I said, I have Dr. Drew. So we have a physician-directed team-based care. When we think about team-based care, it's really knowing that we have that group that is with us to work with us, and if we have chronic diseases that we need to maintain and, to take control of, get more education with, whether it's diabetes, hypertension, congestive heart failure, any of those. And then it's whole person, it's really looking at the whole person. It's not just coming in with, well, this is my complaint today. It's really taking into consideration the whole person and what they still have going on with them. We have care coordination, it's efficient and it's comprehensive. It's sending those reminders. Hey, by the way, you need to set an appointment up, or how's this going, or, kind of taking into consideration how can I give an example? So with my care coordination, okay, I'm going to give again some more, information on me. So my mother also sees my provider. We go to the same clinic. She has breast cancer, and it has progressed. She had breast cancer, and then she got rid of it, and then she ended up with stage 4 metastatic, and it now has since got rid of it. That care coordination team that works with her also has recognized that in my chart, I need to have a mammogram, but I need a breast MRI because of the history of breast cancers. And they have reflected that. And my record also has my mother's name and her breast cancer in my record. And it's really kind of neat how they have, kind of coordinated this care and said, hey, how's this, how's that? And looking at, my needs as well. So looking at quality and safety, care is planned based on what the patient needs and wants, to definitely improve our health. And then enhanced access to care, so if I can't see my provider, do I have someone that I can see? And again, these are things we're already doing. So our team-based care, there's multiple models out there. I don't know if anybody is on from Sparta Community Hospital. I know they were looking, and I want to say it was Dr. Anderson's program, and I can't remember, looking at team-based care and team-based care implementation, or if anybody is on and they've implemented, some specific team-based care models. I would love to hear what you've done. Team-based care is definitely proactive. It's, having your huddles in the morning and really looking at what do you have going on for the day? What information have you or not received yet, on consults or referrals, and really building the efficiencies around our patients. We have defined policies, protocols, procedures, who's doing what, and structured communication. So again, team-based care, while it sounds like it's a lot, and I've never been through the full implementation process, so I can't tell you that, but if anybody is on and has started down this path or worked through some of it, I would love to hear from you. A lot of times I can teach it a lot easier than I can practice it, and what that outcome feels like on the other end, by the staff. So again, if you've done team-based care or working through it now, would love to hear from you in the chat box, just to kind of share some of your experiences. So, or open up your mic. So anybody on that's done any of this?
It looks like, if you saw that message from Joanne Coke, is that she says we're here. So I know you, yeah, there she goes.
Didn't change our process very much. Just felt like tightening up some weak areas. And I agree, it does tighten up some of those weak areas. Anybody else? Okay. So care coordination, care coordination is truly tracking your patient labs, your referrals, your specialists, getting reports back, getting reports back from your emergency departments, to make sure that our patients' needs are met, that we know when they're in the hospital and we are connecting with them to say, hey, let's make a follow-up appointment, really looking at that transitional care, and the whole TCM process. So again, we understand care coordination. Now, when you're a clinic of, 5 or 6 staff, that's hard to do. So really building in some of those processes and communication platforms with your local hospitals, does help. But also, once you have that well-established connection with your patient, they're going to reach out and say, hey, I was in the hospital. This is what I need, and you'll start to feel some of that, back and forth dialogue. Care management, just like it sounds, we've all seen a lot of this when we've done chronic care management education, and really looking at, okay, what's entailed in all of that and the steps with it. looking at our preventative measures as well as our chronic illness visits, our hemoglobin A1Cs that we're tracking them, we're following up with our patients. Medicare well visits, again, an easy target to bring our patients in, really looking at the patient plan of care, medication management, med rec. I cannot say enough about that. And then that ongoing patient follow-up. Hey, it's time for your checkup, make an appointment every 6 months, at least once a year. And then some self-management, that we're helping our patients when they come in. I have a diabetic that's coming in and they've really been struggling as they've gone to carb counting instead of, what they used to be doing and just modifying, their injections or their insulin of sorts. Looking at skill building, how can we help them further? Lifestyle modifications. Yes, you have this disease, and here's some lifestyle modifications we have to take into consideration. I will share, I was talking with a fellow the other day at my granddaughter's preschool picnic, and he had recently had gastric bypass or banding, I guess is what he had done. And he said the skill building and problem solving assistance through the clinic that he was going to, not just for him, but for his wife, they had to make a lot of changes, and look at, the way they do things. When they get together with family outings, what does that look like? And those lifestyle changes. Sorry. Patient emotional support. How do we provide that, or referrals? We recognize if they're having depression or anxiety issues, or, challenges internally. And then, any community programs that we're staying on top of that and saying, hey, what do we have going on in the community that we can really get our patients to be part of? So, and then our access to care. So looking at, okay, they are, needing our services, and we really want to have that flexible scheduling system, that we have some open sick times, or same day appointment availability, looking at, timely clinical advice, when they call in and leave a message for the triage nurse, if we have that capability, that we're getting back to them within, that day, and then the continuity of clinical information, truly looking at, discharge data information is coming to us, and that we are staying in contact with our referral patterns and our specialists, and on top of what are we doing with these patients, if they're part of a cardiac rehab or pulmonary rehab, or physical therapy, that we're getting feedback, and making sure that when the patients come see us, we know what's actually been going on with them. Population health. This is how we really start to get embedded into our community. What does our population say about us? If you're on as a clinic, especially an independent clinic, have you looked at your community health needs assessment in collaboration with your hospital or your health department and the program that they do, to really look at what is the need of the population? What are we not meeting for them? To really make sure that we get to serve them just as much as they come to us as their provider. So, and looking at how we can utilize the patient information clinical data to build those evidence-based guidelines and those services that we need to have, within our clinic or within our hospital. Electronic systems, I know depending on which PCMH accreditation program you are looking at, some do require an EHR system, others do not. So again, it varies depending on which one you go with. So, but we really want to look at how can we, utilize our records, to pull reports, summarize patient information, summarize data, and what gets measured gets done. I know, is always the golden saying in quality, but it's really just looking at, okay, are we utilizing everything to our best advantage for the patient? E-prescribing, are we emailing? Patient portals, oh, hands down. If anybody's got a way to get patients to use their patient portals, I would love to hear it. That is so hard to get them to use that. And then if you have broadband issues or internet issues, or we have the older population that's like, no, I'm not getting in there. I don't have a way to get in there. I don't own a computer. I have a smartphone, but it's not smart enough for me to want to get in there to my patient portal, and, force function some of that. So, but again, we want to look at what are we using, to communicate with our patients, and how are we, really taking advantage of the systems out there, if at all possible, or even just a quick, simple phone call or a simple text message. Hey, thinking of you today. Hope your blood pressure's been under control. Something simple, to really kind of stay in communication with our patients. And again, measurement, looking at the quality improvement, using our data to our advantage, and that full patient experience. When we think about the questions and, what we want to ask patients, when we think about, okay, what questions do we ask? We really want to focus on questions that matter to patients. I know there's the PCMH patient satisfaction survey out there through AHRQ. There's also the CG caps, but and then I know NCQA looks at some specifics with their quality performance and patient engagement. But we want to focus on what matters to them, sending powerful messages to our patients, that we care about them, but also how can we measure that? Are we utilizing telephone calls to measure our patient experience? Mail mode, text messaging, email messaging, ways to capture their engagement, but asking very pointed and specific questions. There's no requirements on which platform you use. It's just looking at, okay, are we meeting our patient needs, and how do we know we are? How can we shine on this? How can we say, this is how we know we are doing well? That's really the preface of it, our patient engagement, and kind of looking at some of the quality and, all around quality of what we want to measure. All right, now it's not going. There we go. All right, so benefits. So there are some benefits to, having PCMH, improve compliance with preventative services, and, kind of like Jolene said, it just kind of tightens up some weak areas, when you do that team-based care, but also better disease management. We can look at our hospital readmissions, our ER utilization, looking at, how are we meeting our patient needs, and then, improve patient satisfaction. And we do become that provider of choice. We are that 5-star clinic that they want to come to. And then our staff roles. So we're going to talk a little bit here on, what do the staff really have to do? And there are some specifics in this, and we talked about those early on care coordination, and management, but really becoming that patient advocate, and really looking at how do they get the patient to open up, asking the right questions so that we're giving them, the information that they need, not just the information they want, but the information they need to make better choices, better lifestyle management, and really control whatever their challenges might be. And that we're giving it to them in the highest level of education for our patients, but we're also working at our highest level of education and, how we can best utilize our registered nurse versus our certified medical assistants, MAs, our CNAs, really working at our highest levels, to be the best team possible for our patients. All right, so let's kind of get into some of the nitty-gritties. So NCQA, they are dedicated to improving quality. They've been around a very long time. They used to have 3 levels. Now I think it's mainly just a level 3 accreditation process for recognition. So, but here's a couple comparisons when we start to think about, PCMH and why seek, recognition. And like I said, I'm just doing these 2. I'm not doing all of them, and mainly just because I see the majority of our clinics in rural entities seeking either one of these. The majority seek NCQA, especially if they're part of a system. If you are an RHC, a lot of them go towards the compliance team because it falls in line with your RHC requirements. So, but both are very good. Now, I will say, so why seek accreditation? And I'm going to touch on this very briefly. Some states are starting to pay, and some payers are starting to pay a per member per month if you are PCMH recognized. So I know one state is paying about $16.47 per member per month. So if you have 100 patients through that payer, you are getting, a good chunk of change each month just for keeping and maintaining your PCMH status. And there's more and more of those states that are starting to do that. Some are through the Medicaid program, some are through private payers or Blue Cross Blue Shield. If you're part of an ACO, it definitely helps in, seeking your shared savings opportunities. But this is, it is something that I just feel like if you're going to go through the work, why not take the recognition with it and shine on that, and shine it and market it to your community. This is who we are, and we are here for you. And this is why we are here for you, and this is what we do for you. So when we look at, NCQA and the compliance team, it makes you think that NCQA doesn't have as many parameters, but when you look at it, and I will show you this here in just a minute, there's so much involved in each one of these 5 levels of performance. So when you seek NCQA, so like team-based care and, managing your patients, there could be up towards, 30 other additional tools and requirements in that. So again, when we look at, so they're looking at, team-based care. Oh, thank you, Joanne. Yes, it is much less work. Just show evidence that you're still doing what you say you're doing. So, and then you'll see on the compliance team, and this is the same with Quad A or URAC or any of those, you have to have team-based care. You have to have practice organization, and these are things that we're doing. We just sometimes don't have it wrapped up in a nice, neat little package and putting a bow on it. That patient-centered access and continuity of care. The same goes into the compliance team, that we are able to help ensure that our patients have access to care, that providers have access to their records. And again, each one of these falls along very similar. Now, I will say some of the quality metrics in NCQA are a little bit different, whereas the compliance team, they used to have some quality metrics. Now they say you have to submit once a quarter your Plan to Study Act program. So your QAPI program, what are you doing to improve? And it could be 1 measure, it could be 5 measures. It's completely up to you. And a lot of that, it can be very simple. It can be, looking at patient engagement or, post-discharge management, that we're calling them within 48 hours of discharge. It could be disease management. It could be ED utilization. It could be, oh man, how are we evaluating our primary care provider versus our specialist? How do they like the specialist that we're referring them to? Or, diabetes management. Are they getting their foot exams, their eye exams? Is their A1C under control? And both of these work, all of these measures work in both models. So it's just a matter of picking the model that's going to work for you. So again, that's about the most I'm going to touch on the various models that are out there. But if you guys want to see some of these, I will show them to you at the end. And I can show you kind of as a surveyor what we look at through the compliance team. And then I can show you the guidance and standards from NCQA. So again, it's kind of up to you what you guys want moving forward. So, but now let's get started into really looking at how do we start and where do we start? First and foremost, find that leader that's going to be that champion of this, really embrace it, but also they're going to be the ones to get everybody engaged. It's not necessarily the manager's responsibility. It's that person that will truly, build the energy around this. And then we're going to educate the team. What does this look like? If we were to create our picture perfect state of PCMH, what does it look like? And then, our plan to get there. Look at a practice readiness assessment or a policy assessment to say, okay, if we're going to look at this, what do we already have in place? What are we already doing? And we've just not, shined on it. And then creating that project implementation plan. And I don't know if anybody needs any of these tools. I did not provide them, but I can, when we're done in the portal of where you're going to find all of this information. So we definitely can put that out there for you guys. And then develop that plan for health information technology. Okay, so what are we using? What do we need to use? Are we using it to the benefit of the patient? Are we using it to the benefit of the clinic? Both, not at all, and how do we move that step forward? And, what do we already know? What can we already abstract? Do we have a clinical informatics person that can help us in building the right templates or the right triggers to pull data, and then prepare for implementation. So we're going to begin our transformation, and our leaders, and this is not just the leader leading this team, but it's all of our leaders, is that vision for change, and what does that look like? Setting that direction and, that framework and that, really kind of creating that heartbeat of what we want, for enthusiasm and, just kind of keeps us moving forward. And then we're going to identify, changes, small tests of change are, essential. Does it work? Does it not work? What did we learn? And how can we modify it and do another small test of change? This isn't something you chunk off and do. It is something that is going to take a true transformation and journey, through this. So we're going to create our implementation plans. Our plans really should be comprehensive, but focused. When we are identifying one area that we're going to work on, let's create it actionable but achievable, and that we have some accountability set. Looking at, how do we really kind of set the stage and put these operations and processes in place, and incremental tests of change and movement forward, is essential. We don't want to do this all at once. Now, some of you might already be NCQA and you may have been part of it at the onset, you may not have, but there are challenges. I will tell you, the staff time is a challenge, and change with staff is a challenge. So how do we improve office efficiencies and, break bad habits? I cannot say enough about finding those workarounds that staff have done. And this isn't just in PCMH, it's in all settings, that, well, we've always done it this way, but this is my workaround. And my policy says this, or procedure says this, but I'm not doing it that way. I do it this way. How do we improve that, and the efficiency of what we do? And then, really looking at, are we reducing our patient wait times? Are we reducing the amount of no-shows that we're having? Looking at how did we improve care coordination and transitions with our specialists on our hospitals? How are we communicating with them, giving them feedback, but also trying to get feedback from them? Utilizing nursing staff to really educate our patients, and again, the highest level of their certification or recognition or degree, and fully implementing electronic health records can be easier said than done. Or if you are, some of the clinics I'm working with are going through a transition of change of their EHRs, and it's hard, to work in two systems while you're going through that change, and then having to go back to the old system to get everything integrated. So again, how are we going to do all of this and creating that plan? Some lessons learned, and this is again, where we need to pipe in and share, for those of you that have already gone down this path, that it truly takes a commitment and passion to be on this path. It is a journey, and this is a true transformation of where we want to be. It's all about building our relationships. It's, as a team, amongst our clinic staff, as well as our other healthcare professionals that we work with and our patients. It's getting creative, start small and build on what's currently working, identify that. One of the things I can say, the best thing we ever did in one clinic was the sticky note method. And, I don't know, I know they call it the affinity chart and all of that, but it's really just putting sticky note out and big whiteboard. Actually, we used wrapping paper and we put that up on a wall, and everybody put sticky notes of all of the challenges they have or all the concerns they have. And, we just started, identifying them and then grouping them and then saying, okay, this is the one we're going to work on first. We voted on it and said, this is what we want to attack first and fix, because this is the biggest pain point in our internal working relationship with each other. So now you may need to add staff or change staff. And I can't tell you either way on that, depending on your clinic, your volumes, and what you're doing. But I can say, no matter where you're at in it, you have to really engage staff to be part of this. So, and again, if you wait for everything to be perfect, you'll never start. So how do we get there, and just to take that initial step? So, and I know I'm almost done with my slides here, and then I really want to open it up to questions with everybody. So again, recognize the risks of change overload. And do sequencing of change, small tests of change. Don't put it out there for all of this. Yes, you're going to do some initial education on it, but then remind staff, hey, we're not going to do all of this all at once. We're going to identify one of our pain points or one of our concerns and fix that first, and really make sure that it's, that it's ingrained and it's part of our daily practice. Effective teams, and it's not just effective teams, it's about communicating with all of our teams. And we're going to come over to this, somebody's writing in here too, really looking at, how are we making changes within the people, but, it's how they communicate with each other, how they work with each other. I had one clinic that there was actually a little bit of rivalry. Some of the staff nurses that were rooming patients were frustrated that certain nurses got to be care coordinators and spend all their time on the phones. And they felt like they were office nurse, and sitting there and they weren't doing anything, not realizing all the work that was behind the scenes until we allowed them to shadow or sit in that role a little bit and really get the feel of what these people did day in and day out, on some of these calls. Change fatigue is a serious concern. Cannot say that enough. You do not want to create burnout right from the get-go. And then looking at the value of internal and external quality improvement coaching, and bringing in those coaches and those cheerleaders to help make the move and the transition. So I know we've got a note out here on the chat board. We've seen several studies over the 6 years or so, including one in the last couple of months, that have indicated PCMH does not contribute meaningful savings or outcome improvements. Is there alternative data that says otherwise? If so, what appears to be the difference in the data sets that make them come with the opposing conclusions? I have heard that too, and I've not seen a lot of the data. I would love to try and get into some more, and I will. But I do know that, some of the states that have payers that say, hey, we're going to give you a per member per month recognition. And now they're also part of ACOs, a couple of these that I've worked with. They have definitely shown benefit in improving mammograms, improving their A1C management and control of their patients, and showing the value. Carthage Memorial Hospital, which is in Illinois, they were a shining star with the compliance team back in the day. And I can't remember, this might have been 3 years ago, maybe 2 years ago. But they were showing that they had 55 frequent emergency department users, so these folks were coming into their ER, high costs to the ER, that weren't always getting paid as well. So they started on their PCMH journey looking at ED utilization. And they started communication with all 55 of these patients. Through that, they started scheduling office visits and self-management skill training of their diseases. They had them coming in and doing some nurse visits for education purposes. And they monitored them for a full quarter after they started this implementation process. Now, again, these were 55 different ED users coming in more than 6 times per year. And a couple of them I know were coming in almost routinely once a month. So, but once they set that in stone, and after that first quarter of initiation, they only had 1 return ED visit out of those 55. I mean, so they're having amazing results. Now, are there other points of data that we could find? Yes. Do I have that handy right now? No, but I know there's things happening out there. And I know there's a lot of these success stories in showing utilization, showing chronic care management skills without truly implementing the CCM program, but they're showing the engagement of the patient with the provider and coming in routinely for those routine visits. So I hope I answered that question, but it's a great question that we will take note of and see if we can find some true data otherwise. So very nicely put. So again, we know change is hard. Everybody has to face change, and we know really trying to change our personal habits of what we do, even as leaders, and how we do that, requires a commitment on our part. Really looking at, how do we change, our own bad behaviors that we've done, and kind of stepping up our games, to show that, hey, we're in this to win it, and we're in it for the long haul. So, and then that sustainment of change, because after a while, some of those old habits kind of trickle in. And this is something that we do need to recognize. And when we are putting our plans together and we're doing our small tests of change, and we've started to see success in our small tests of change, then we also need at the beginning is to say, hey, how can we recognize if we start to slip? What does that look like? How do we recognize that this is not sustainable, or we are starting to drift back into old habits? So again, looking at, what does that look like? And having staff recognize that ahead of time, is key, so that we can address it when we start to see it. When we start having our huddles or we start to fail at our huddles, we're not doing them, they're not happening. What does that look like, and how do we get back into, our true journey and where we're going? So summing up, some medical home is, truly where the patients feel welcomed. We are getting to serve our patients. We are getting to serve our community, and we're energized every day for what we are doing, and I know we're living in the world of, the COVID and, the efforts to keep it out of our, healthcare entities and our communities. But now it's, we've exhausted, our energy on that. And we need to find something to rebuild that energy in our staff, and again, like I said, a lot of this you are probably already doing. So it's a matter of, looking at what can we do differently. So these are some resources. This is just a lot of the different ones. I don't think I have URACs on there, but I do have everybody else that, the Quad A, the compliance team, NCQA, the American Academy of Family Practitioners. They also have some nice tools out there. And then AHRQ also has some nice tools out there. So, but I am going to try and find another screen to show you guys. So just so you can get a feel for what some of this looks like. Oh, hang on a minute here. So I don't think you can see that yet. All right, so this one I'm going to take you through. And again, this is the compliance team's version. So when we go through it, we have our patient-centered medical home and we have some specific measures, and, just looking at, okay, we have provider-led teams, we have subsequent visits, we're scheduling our patients, we're utilizing certain protocols, procedures, really looking at each one of these steps. And you'll see as you read through this and kind of just perusing this, and again, I'm not allowed to share this physically with you guys, at least not yet. Kate doesn't want me to, but I am going to show it to you just so you get a flavor of us as surveyors. This is our tool. This is what we use, and this is what we say, hey, we're coming in, we're going to look at this. How are we communicating with our specialists, our pharmacists, looking at, any impairments with our patients, that we have set a goal with our patients, looking at something with them. I just want to be healthy. My big goal is to drink more water, and my physician knows this because he tells me this all the time. You need to drink water. And I'm like, yes, but I drink coffee and that's just flavored water, but he doesn't buy that. So for the first 3 months of me changing my habit, his care coordinator was sending me texts saying, hey, are you drinking your water? And I'm like, that's really cool. So again, it's setting those standards and those expectations. So really looking at, our patient needs assessment. And does our EHR allow for a patient needs assessment? Do we need to create one? And what does that look like? How are we really addressing all of their needs? And we're communicating with them. So, and then again, just still kind of going through here, it's not very large. A lot of these fall in line together, as you can see. Do we offer same day appointments? And do we offer expanded weekdays, evenings, weekend appointments? How are we doing that? How are we addressing the needs of our patients and our community, to be their provider of choice? So again, this just gives you one flavor of what this looks like. So now I'm going to take you to the other one. I've got to stop share just for a minute. And then this one is NCQAs, and hopefully you can see this because I can't tell exactly what you're seeing. But this is their table of contents for their standards and guidelines. And like I said, they have each one of their competencies under their module. So you have all of the 5 modules, and then each one has its own competency and its own list of things. Very similar to the compliance team, but more robust. And if you're an RHC, I'm sorry, I mean, the compliance team, it flows nicely with the RHC guidance and the state operations manual and their requirements. So again, it's a matter of picking and choosing, and what do you want to really hone in on? So as you can see, their table of contents, each one of these still were patient access, care management, and the different ones under there. They all flow together, granted. It's just a matter of which one you want to do and which one speaks to you, overall. So, and again, if you guys want these, I don't know if you have to pay for them yet. I know some places you have to get NCQA stuff, you have to pay for them. I was lucky enough to already have these for another project I was doing, but I will gladly share these if you want them. And I have all of their standards step by step. So with that, I'm going to go to questions. So, oh, no. Oh. And we will open it up. So now it's question time, question and answer time, and really looking at, okay, what can we do? What can we do to help you? What is that fear of going down this path? And I know a lot of people are going to say staffing and time. I guarantee that's, that as me as a clinic manager, that would be mine. That's what I would be saying. It's staffing and time. I don't have the time to do this. But again, if you do the initial assessment, you'll find that you're already doing a lot of this. Even if you take, one piece of it, I think, do I have it up? I don't know if I have a copy of it. AAFP had a really nice, oh, here it is. I'm going to share my screen one more time. So this was just kind of cool. And this is older. This is through the family practice group, but it's a nice checklist. So even if you just took this and said, am I doing this? Am I not doing this? You will find so many of your check marks are there. So there's a lot of this that you're doing that you just need to, like I said, package it a little bit differently and hone in on it and get your staff embraced with this, and look at it a little bit differently. So, but again, now is the time to ask some questions. We do have some folks out there, once you get recognized, it is much less work to maintain. And, I am so passionate about this and really getting people to embrace the patient-centered medical home models. And granted, several studies have said that it's really not worth it. It is, if you are doing it for the purpose of being that provider for your community and looking at how can we benefit our patients, not how our patients benefit us. Other questions, thoughts? Did this help? Did this overview help? And is there any resources you guys would like to have from us? If you guys want some of this stuff, I will gladly. Are there any open source case study examples of PCMH demonstrating pre and post accreditation value? I would have to ask. I know Kate from the compliance team uses Carthages. So that one, it definitely had provided financial benefit and impact. I know there's another one out in Colorado, and I can't remember where they were. They had substantial impact when they started going down this journey. So. Anybody else? And I know it's hard. I know it's fearful. There was a reason that drove you guys to come listen to this. What was it? Why did you want to listen to this webinar? Why did you want to see these, and kind of look at it? What was that little bit of, hey, I've got this little nudge of saying, hey, I want to do this, or I want to know more about it. What can I provide, or how can we at the center provide for you and help you with this? Additional resources and a copy of the presentation slides. Yeah, you will. I know the slide deck is going to go out to everybody, and I will put out more for you guys. So,
Yes, there will be an email that will come out pretty soon after this webinar, as we're concluding this series, that will have links to all of the this session and all the previous sessions as well. So they'll be all packaged nicely on our website, so you'll have access to all of those and any resources that we can share as well.
And again, if there's education topics you guys want, holler. I will gladly bring them, or we'll find a resource to bring them. I just need to know what you guys want. I know Kim and, Caleb, they all put out these surveys of, hey, what would you like to hear? And we project some ideas of things that we think you might want, but we don't know, do you want something on leadership? Do you want something, on project management, or, I don't know. Again, we don't know exactly what you need, so we try to bring, a very high level of something, say, okay, and then let's start this next series. We'll do another series of 5. I don't know when that's going to come, whenever, Caleb or Kim want to bring me back. Yeah. So, but, let us know what you want, because we are here to serve you guys. That's why the center exists, is to bring these resources to you.
Yeah, you're exactly right, Angie. And in that email linking to all of this webinar and the previous will also be that survey, just exactly what you're talking about. So if you don't have any ideas right this second, or you need a moment to think about it, or if something comes up, you have a link to an evaluation for this series, but also an opportunity to let us know exactly what Angie's speaking of, what you need. So, as we work with you all through the consultations and through other projects, we take note of things needs that come up that we hear on a recurring basis, but we always we always love to hear, of other needs that you all have that maybe we don't hear about from time to time. So absolutely, please share those with us in that survey or at any point in time.
All right. Well, hearing nothing.
All right, awesome. It looks like everybody is super thrilled and has all their questions met. So we'll start the post-polling questions there. Looks like folks have started those. So this will be 2 questions here, same as the first. We want to know about your understanding of the best practices for patient-centered medical home implementation.
And if anybody decides they want to go down this path, I will gladly, just reach out, shoot me an email and say, hey, we're getting ready to start this. Can you just help us get the kickoff going? What should I do? How do I approach my staff with this and make it not be more work? Because, we all have that fear as well. So again, give me a shout.
Mm-hmm. Absolutely. That's a great offer there, Angie. And the second question is, we'd like to know how you will apply this knowledge gained with your with this training, with the educational training, to encourage your quality improvement within your organization. Yeah. So.
Thanks, Nick.
Yeah. The responses are very much more focused than they were earlier. They were kind of all over the place. So that's awesome.
Yeah. So again, I appreciate that, everybody. So
that's why
I will be shooting some more stuff over to Kim and Caleb of these resources that I can share. And as soon as Kate gives me the go ahead to share the stuff from the compliance team, I will gladly do that as well.
Wonderful. Thank you, Angie, so much.
Yes.
This has been a great series, and I have a feeling we'll be seeing Angie again. So
I hope so.
No worries there. Yeah, we'll be hearing and seeing from her again in the near future. And we thank you all so much for just joining us for this series. And we have more education coming. You'll be hearing more about that. You'll see it in emails and newsletters. So be on the lookout for that. And we thank you all for joining us again. We wish you a great rest of your day and week. And thank you all. And again, a huge kudos to Angie and you're sharing your information and your knowledge with us.
Thank you so much. You guys have a great rest of your summer.